Thank you once again, Manos. It's a pleasure to be here and to present to you our experience with starting up doing arthroscopic Latarjet in our institution. The background, as we already said, was published by Latarjet and Helfet, and in Norway this was the preferred procedure in revisions and in patients with major bone loss. Then came the arthroscopic Latarjet with some frightening references to serious complications, and this led to large amount of doubt in the United States if this was ever going to be acceptable procedure. Editorial comment in this number of arthroscopy in 2018 was it? Arthroscopic shoulder, Latarjet shoulder stabilization. Where are we? When are we going? Where are we going? And also the wake of the dragon. Will the orthopedic community ever adopt the shoulder arthroscopic Latarjet procedure? So it's been a lot of discussions about this. And you can easily understand that there are discussions when you have a well-working open procedure and you have reports of dramatic failures and complications when introducing arthroscopic procedure. So we were thinking about this for years and years and could not really make up our mind of what we should do, if we should continue the development of arthroscopic techniques, or if we should stay with our combined approach to do something arthroscopically and something open. As you see, our department, we have about 100 surgeries a year. The majority of patients, about 80%, treated with Bankart or Bankart remplissage. But we experienced problems in young males in contact sport, recurrent dislocations after surgery, hyperlax patients, and significant glenoid bone loss, and in those patients that really has no soft tissue available for a soft tissue procedure. So, what would be the arguments for an arthroscopic versus an open Latarjet? Well, the possible advantage would be less pain, as we frequently see with arthroscopic procedures compared to open procedures. Less scarring for sure, because there are numerous but very small incisions, and they disappear after a year. You could, as from all endoscopic operations, expect a lower infection rate, because of you don't expose the tissue to the air and to infection, and you also have a continuous lavage. We expected to see a more precise graft positioning because the experience from arthroscopic procedures, in contrary to what our former bosses told us, that if you wanted to see, you had to open up, that's not the case. If you want to see really well, you should use an endoscopic technique, because then you can come close and you can really see the details. So we expected a more precise graft positioning, and from there probably also less osteoarthritis. Cosmetics could be of some importance in females. The disadvantages are obvious, technically difficult, yes, longer operating time for sure in the beginning at least. And for sure, the risk of severe complications and lack of appropriate technical skills. So there has also been reports about insufficient fixation with some of the current devices, so that was also to some extent a concern. After long discussions, discussed with Tom, I finally decided that we would get started. And part of this was because I got a new surgeon working with me who had extremely good talents in arthroscopic surgery. And I said, this is not something you could do on your own. You need to work together if you should accomplish a turnaround like this. So we limited the procedure to 2 operating surgeons, and we decided on doing registration of operating time, a CT scan pre-operative, post-operative, and at 1 year, and do a VOCIS and constant score pre-operative and at 1 year. And we also designed a scoring system for graft positioning. Our material, from the start in November 2014 to November 2019, we treated 103 shoulders in 102 patients. It's a consecutive series where all Latarjet procedures in this period are included. No patients were converted to open technique, and there were all open operations performed in this period. So all Latarjet procedures were done arthroscopically, and everyone is in the material. VOCI and constant score was organized by our physio, and then we decided to have a look at what was our learning curve. So we decided that we should compare the first 25 shoulders to the last 25 shoulders. And the primary effect measure would be the VOCI score, but we also looked at operating time, at complications, graft positioning, and patient satisfaction rate. In 85 out of the 103, we have complete data. In 11 patients, we have incomplete VOCI. That is a PROM, and it's hard to check for every single patient that every single point in the VOCI score is filled in. And if it's not, you can't use it. So we had 11 patients with incomplete VOCI scores. We had 3 patients with drug abuse that were lost to follow-up. 2 patients never returned for the 1-year follow-up visit. One of them, actually, we are still in contact with, and he is doing quite well, and he's listed for an operation, similar operation in his opposite shoulder. And 1 patient died. That was a patient with severe diabetes mellitus, and he had all the complications that you can imagine, and he died in probably some attack of hypoglycemia. We don't know for sure, but he died. 1 patient emigrated. So that leaves us with 85. 19 of the 50 patients we here compare were recurrences after former surgery. And the mean bone loss in the 2 groups were 19% and 20% respectively. So what are the demographical data? You can see that there is really no difference. Gender, same. Dominant hand, same. Hyperlaxity, same. No differences. And this actually tells us that even if this series developed over more than 5 years, we did not change our indication during this period of time. So it was the same kind of patients we treated all the time. Median number of dislocations before surgery, 10. So you see it's not the easy treatable patient we select for Latarjet procedure. And pretty high mean glenoid bone loss, and some of them with seizures in both groups. When it comes to complications, we graded the complications in relation to severity. So grade 1 is an incident that had no influence on treatment and recovery. Grade 2 is an incident leading to a prolonged or changed treatment or recovery. And grade 3 is an incident that is leading to a reoperation. So what are the results? When we look at complications first, you can see that we had 5 grade 1 in the first group, none in the second, 7 grade 2 in the first, 3 in the second, 4 grade 3 in the first, that means 4 reoperations in the first group, and only 1 in the last. So there is a major difference, total 16 compared to 4. But as you can see, these are mostly minor complications that has not really changed the recovery of the patient. What we found that was kind of unexpected, that was that we find at 1 year more than 50% bone resorption in about 40% of the patients. We had, in the whole series of 103 shoulders, no serious loss of neural function. We had one patient with temporary dysesthesia in the C6 area that fully recovered before we actually got to a neurophysiological workup. That was one patient in group 1, possibly related to traction and bending the head to the side. We had one patient with light and diffuse dysfunction in group 2. That was probably also a plexus-related traction. He had a positive EMG at the workup, but recovered completely at 1 year. In the first group, we had 4 reoperations, one for a postoperative infection that was underwent lavage 3 days after and recovered uneventfully. One patient had to have the screws removed because of irritation, and 2 patients had to undergo arthrolysis due to range of motion deficiency. And that is something we actually learned, because in the beginning we were told that we should do the subscapularis split at the border between the upper and middle third of the subscap. Then we realized that we had several patients with limited external rotation, and somebody told us that you should go lower. So in the later group, we did the split of the subscap in the level between the middle and the lower border. So we put it 1/3 lower, and that resulted in much less problems with external rotation. We had one reoperation in group 2 that was because of graft breakage in the postoperative CT, so we had to take him back and fix the graft open in a different way. What about operating time? As you can see, it was an improvement from group 1 to group 2 from group 1. WOSI score pre-op was the same in both groups. WOSI score difference was not statistically significant, but a little bit higher in group 2. And the satisfaction rate of the patients were 21 of 25 in both groups. What about the radiology score? Here you also can see that the last group had a higher score than the first group. So we have had no redislocations in this series so far. We assume that patients has got in touch with us if they had problems and after the 1-year visit. And we have now started the long-time follow-up of the whole series. 3 of the patients in group 1 have minor symptoms that can be instability related, none in group 2. So, what about the assumed advantages and disadvantages? Less postoperative pain? I'm not so sure. It's hard to tell because it's a great variation from patient to patient. Some of them really want to go home on the same day, have no pain at all. Some of them have a lot of pain, and we can't really relate it to the operating time to the procedure itself. Less scarring, yes. There is a cosmetic gain, and our female patients have been very thankful for ending up without scarring their shoulders, so they can wear a dress with low shoulders exposed. I don't know, less postoperative infections. We've had 1% infection. That is about what to expect in a planned surgical series, maybe 2, but it's hard to say. Precise graft positioning, also doubtful. It turned out to be much more difficult than we thought to find the right position of the graft when you only visualized it with the arthroscope. But what really has been beneficial is the traveling from arthroscopy to endoscopy, because we have got a lot of new knowledge and new possibilities with endoscoping the subdeltoid subpectoral compartments. Disadvantages, technically difficult, not that much. That's a question of preparation. You have to prepare yourself, you have to study and learn, and then it's absolutely feasible. And I advise you that you should be 2 surgeons working together. That helps a lot. Longer operating time, yes, in the early phase. In the latter series, I don't think so, because many of the patients also were treated with remplissage, which would have been extended the operating time in an open procedure significantly. Increased risk of serious complications, probably yes, but we have avoided that, and I think the main issue there is that you never continue working if you can't see. So it's mandatory. You must see what you do, and if you can't see, you have to wait till you can see before you move on. So in conclusion, the first group has longer operating time, more complications, and worse graft positioning. At 1 year follow-up, there is, however, no difference in patient satisfaction and function. Complications were overall mild and transitioned, and we had no serious nerve complications, which I relate to the fact that we never, ever avoided exposing both musculocutaneous and axillary nerve. We would always visualize them and know where they were. And that we learned from that both nerves can have a very, very different position from patient to patient. It's a great variation in the anatomical position of these nerves from patient to patient. We have started the long-time follow-up and will show if these results persist or change over time. So, conclusion, with good and thorough preparations, we state that it is safe to change from open to arthroscopic technique in Latarjet procedures. We have gained highly appreciated knowledge and experience with endoscopy of the subdeltoid subpectoral space, and we will not return to open technique in Latarjet. Technical improvements of both surgical procedure instruments and graft fixation are to be welcomed. And as Manus showed us early this morning, we have developed what we think is an improved guide, useful for both bone block procedures and Latarjet procedures. Useful because it is easily to position in the right position because it slides over a swishing stick. And it's very, very atraumatic to the tissue, and you don't have this scuffing of the articular surfaces that you can have with a metal guide. Thank you.
Any question? I give you one. So definitely the less pain that is questionable or the cosmesis that is possible is the main advantage versus the open Latarjet. Is it? I mean that I would move to an arthro Latarjet, and I had a series. The 2011 I did several, but I then moved back, and I again would move to the arthro Latarjet if it could allow me to treat some side lesions, because we know that we may have posterior lesions, we may have a Hill-Sachs lesion or superior labral lesions. So we have to know that should be several advantages over the open Latarjet that is blind versus these other lesions. Do you mean that we can improve the Latarjet technique going arthroscopically instead doing as a rule the open one?
The short answer to that is yes. The more complicated answer is I have to tell you a little anecdote. I was the first to publish and present the result of arthroscopic shoulder surgery in Norway. We had a series of the most common shoulder operation at that time, the subacromial decompression. And I presented this at our annual meeting, and all the professors from the university and all the old guys were there, and they started laughing. This was the most ridiculous thing they ever heard of. Of course you couldn't do this operation arthroscopically, you had to open up to see what you were doing, and that was for sure. That was also the same for meniscus surgery. For a long time, it was a statement that if you would do arthroscopy to do the diagnosis, and if you found a meniscal tear, you would have to open up to resect it. So I think in line with this, there is a road that is sometimes wider, sometimes more narrow, that leads in one direction. And I think the direction is towards endoscopic, minimally invasive surgery. I think we are still in the early phase on many parts of it. And Latarjet is one where there is big possibilities of improvement. So I think that will come, and I don't think that 20 years from now everyone will have abandoned arthroscopic Latarjet procedures. I think more people will do them. But I think, and that is the problem, with all the other techniques that are described, there will be less and less patients that need a Latarjet procedure. Because we should remember a Latarjet is an extra anatomical procedure with a lot of complications, whatever way you do it. And if we can cure these patients and treat them with simpler procedures, like Manos was telling in the former session, there will be less and less patients that need a Latarjet. And that is a problem when you have a technically complicated procedure. If the numbers are so small that only a big center have referrals from all over can do them. That is a problem. So we will wait and see.
Thank you so much for the presentation.
So now it's time for a
Question
Yes.
to you.
One question before the coffee break.
Sorry. At first I want to compliment with you for your presentation, very clear, and I learned a lot. I just want to ask two questions. The first one is, I perfectly agree that the problem is not arthroscopic or open, but the problem is Latarjet, yes or no? Perfectly agree. And I think that in the future, we will do less Latarjet more and more. But beside that, I want to ask you two things. The first one, I don't understand about the reabsorption of the graft. You of the coracle. You saw 50% of reabsorption. Is that correct? Or
No, in 50% of, in 40% of the patients, close
Yeah.
to 40% of the patients,
you find
we
a
have
reabsorption.
more than 50% resorption. And that means we just had a cutoff at estimation at 50%. We had only one or two patients in the whole series that had a complete resorption.
So, but
Yeah.
there is
Yeah.
partial reabsorption.
Partial absorption.
50%.
40%.
40%.
Yeah.
No matter what kind of fixation you did.
Yeah, it was all screw fixation.
All screw fixation.
All screw fixation. Same procedure in
Okay,
the
so,
whole
so
series.
it's a lot. It's a high percentage of.
It's a high percentage. We
Uh,
were surprised.
Yes. So the question should
But
be.
that is a good example of that it is nothing that ruins a good result as much as an extensive follow-up.
Yes, you're right. And so the consequence is that the bone block of the Latarjet is not, maybe it's not so focal. The second thing, I doubt that 1 hour 30 minutes is the standard timing for an arthroscopic Latarjet, because I think it's a little bit more the timing of. Is it true, or
no.
is it you're serious?
130 minutes is 2 hours and 10 minutes was the mean for the first group.
For the first, I didn't.
2 hours, 2
and
hours and 10 minutes, 130 minutes. Yeah.
I understand.
Yeah.
Okay. Thank you very much.
Yeah.
And still, it was very quick.
Yeah.